set up.
Question?
Yeah.
Here you go, Joe.
Going back to the waistline and with young women that are pretty flexible, and that seems to be a more common problem that they have a negative MRI. How would
Yes.
you diagnose that without the arthroscopic?
Oh, perfect. I'm glad you reminded me. So Sean's been working with me now for a little bit, and so I always kind of ask him, you know, hey, so what do you want to do here? What do you want to do here? What do you want to do here? And a lot of times my answer is diagnostic injection, because the hip lives in tiger country. You've got hernia issues, OBGYN issues. We've even had one guy who had testicular issues, lower back issues. Everything all kind of crosses through that region. And so for me, we kind of have 5 things, and this is the other thing Andrea and I are working on right now. So we have 5 things that we look at. One is the history. Does it smell like a labral problem? You know, does all these things start to sound alike? Do we reproduce some of their pain with the anterior impingement maneuver? X-rays, do they have impingement in a preserved joint space? MRI, do they have a labral tear or not? Okay, but that's the one that sometimes isn't always there. The last thing we do is we do a diagnostic injection. Now, there are a lot of ways to do it. A lot of people will, when you get your MRI, throw some cortisone in, throw some lidocaine or marcaine in, and do your MRI, and then see if that makes a difference. I tried that for a little bit because I thought that was a smart idea. The problem with that is that you inject so much dye into the joint that from a pressure standpoint, you create pain. And so sometimes the lidocaine and marcaine can't offset that. When we do it, we just do marcaine and lidocaine. I could do it myself, but I probably would miss 10% of the time. And if we're making a surgical decision, I don't think it's safe. So I send them to one person at Touchstone Imaging, and she's brilliant. Tina, she's brilliant. And so usually it should be a painless, relatively painless experience for the needle. It gives the patient 2 or 3 hours. So they run around on it, they twist on it, they do the anterior impingement maneuver, they tell us what goes away. And then from that, we use that as an objective mark. So typically what we'll see in those patients who have the wave sign is they're able to run around, they feel great for 2 or 3 hours, and then the injection wears off and they hurt like heck for a full day because they did things that they haven't been doing for a while. And so that's a positive response to diagnostic injection. That's how we get those patients to determine that this is going to be a helpful procedure. I'm sorry I forgot that. Thank you. Okay? All right, so I'll turn it over to Joe. Here, Joe, you got to do this.
I just need that one, unless you're videotaping me as well.
No, yeah, we're going to videotape.